So I'm going to talk about pathophysiology. I have a set of disclosures which you have relating to trying to find new therapies or patient safety with toxic effects of drugs. I'm going to talk about definitions and diagnosis first, and then pathophysiology, but you'll see there's sort of a mixture. The title of the talk is Pathophysiology, but it relates to all these other things too. So normal repair, the association of AKI to chronic kidney disease with maladaptive repair, and then potentially a few slides about the future in the regeneration of new nephrons. This is going to be sort of a high level. I mean, we'll talk about specifics of some of the data, but I'm not going to be listing, how to treat AKI in this context or another context. I'm going to talk more general concepts. And then other people coming after me, and you've heard some of it already before me, are going to be talking about specific syndromes of AKI, and hopefully my talk will serve as a foundation for those talks. So, there's a great interest internationally. This is the International Society of Nephrology, which has as a goal to have the incidence of preventable acute kidney injury worldwide to be 0 by 2025. So let's go back to the definition. And this was some work that, this is a summary, actually, diagram that came out of work that Glenn Chertow did when he was at Stanford, but with the Brigham database. He was previously at the Brigham. And this was one of the early studies that showed that a change in creatinine of 0.3 was associated with a significant increase in mortality. And there was another study from the Cleveland Clinic in operative patients at the same time or shortly thereafter that again drew the focus back from acute renal failure to acute kidney injury, with milder changes in creatinine as being very important. So it wasn't necessarily the case that you had to have a full-blown presentation or course of acute renal failure. And that resulted, this study was one of the initiating studies, but this whole transition to thinking about, number one, changing the term, acute kidney injury rather than acute renal failure, and then talking about the, as I will now, about staging of acute kidney injury and relating that to outcomes. A couple of different groups came together over a few years, and ultimately the definition of AKI that most people use right now is the KDIGO definition, which is defined as a rise in by greater than or equal to 0.3 milligrams per deciliter within 48 hours, or serum creatinine rise to 1.5-fold baseline from the reference level over a period of 7 days, or a urine output criteria, which is basically less than 0.5 milliliters per kilogram per hour for greater than 6 hours. Now, that latter criterion is something that's really only relevant if you know what the hourly urine output is in the ICU, for example. Okay, but using this definition, the incidence of AKI, as all of you probably well familiar with, is quite high, especially in critically ill patients. And this was a summary put together by Bellomo and published in 2017. And you can see here in the incidence in, again, critically ill patients is often above 50%. So this is clearly an entity for which we have I'll say right up front, we have no good therapeutics at this point, but which is obviously incredibly important for our patients. The staging, it's not terribly sophisticated, but the higher the change in creatinine, or the greater the change in creatinine, or the greater the reduction in urine output, stages the disease in a sequential way from stage 1, which is the mildest form, to stage 3. Initially, there were 5 stages, but in fact, that's been reduced to 3 stages. And for example, stage 3, which is equivalent to failure, is defined in having a creatinine that is 3 times baseline, or 200% increase over baseline, and or anuria for greater than 12 hours, or this reduction of to less than 0.3 milliliters per kilogram per hour for greater than 24 hours. And it's not surprising then, if you look at hospital survival or other outcomes, that with increased staging, so going from no AKI here to stage 1, stage 2, stage 3, with an increase in the creatinine, essentially, or a decrease in urine output, that mortality tracks that, and any other criteria that you want to sort of associate with critically ill patients. It's also the case, this was a study that looked at the degree of change in creatinine or reduction in urine output relative to the length of time that persisted. So in a simplistic term, if you have a change of, let's say you have stage 2 AKI, which is 100% increase in creatinine, doesn't matter whether you have that stage for 1 day or 7 days. Well, it turns out that it does matter a great deal. And if you have, for example, the duration of AKI for greater than 7 days, then that's this back group here. And whether you have stage 1, stage 2, or stage 3, your outcome, your mortality rate is greater the longer that you have this impairment, or the definition, by definition, that we've used, a KDIGO definition. Whereas if you have a short duration, less than 2 days, it actually, at least in this study, didn't matter whether you had stage 1, stage 2, or stage 3. And one could argue that in the short duration group, it may be due to hemodynamic factors. So some of our patients can have significant increases in creatinine based on hemodynamics. You correct the hemodynamics, and in fact, the creatinine comes back down. Again, none of this to active clinicians, none of this is really surprising, but in any case, it does give you what you sort of expect might be the case. It's really a combination of the extent of the change in creatinine, or the reduction in urine output, and the length of time of that reduction, or reduction in urine output, or increase in creatinine. Now, some caveats, though, in terms of this definition. We actually wrote an editorial a year ago in Lancet titled Acute Kidney Injury, A Problem with Definition. And I could have the whole talk based on this issue, but there are a number of problems with using creatinine, let's say, or even using urine output in terms of the definition. It's a functional definition in GFR if you're using creatinine, but it doesn't really tell you anything about whether, or at least it doesn't have to tell you something about whether or not there's underlying injury or underlying tubular damage. And one of the reasons, for example, is renal reserve. So young people who have normal kidney function can have a great deal of injury with no change in creatinine, and perhaps a little bit of reduction in urine output, but they have a significant amount of renal reserve. Okay, so if you stress them, you can actually pick out this renal reserve by looking at GFR. If you give them, for example, a protein load or something like that, they have a lot of leeway. Whereas an individual who's got some underlying renal disease has less renal reserve. So for the same amount of damage, that individual with less renal reserve is going to show a change in creatinine, whereas the younger person with perhaps a great deal more injury will not even budge their creatinine. So if we rely on creatinine alone, as we do in the field, there's a problem with the definition. And this is an example here. If you can, here's a normal baseline GFR. And if you, let's say you have renal reserve, the renal functional reserve, RFR, if you have this group, Ronco wanted to call it a kidney attack, which I don't think is a good term, but nevertheless, some kind of kidney injury, you actually won't reduce your GFR to below normal. And after the injury, you'll go back, your GFR will, and your renal functional reserve will be maintained. But with increasing injury over time, your renal functional reserve goes down, and any change in or any recurrent injury or any kind of injury at all will result in a significant drop in measured GFR. And here's an example of a paper with very few patients, but it sort of makes an interesting point that if you're 25 years old, here's the renal functional reserve, and you give, a protein load, your GFR can increase from 122 to 226. On the other hand, if you're 77, a group that was, again, a small number, but as patients age, giving the same protein load increases their GFR from 51 or 52 to 72. All right. So this has a significant, so put in the context of this whole story of AKI, if we focus on creatinine, we just have to be aware of these caveats. All right, another thing, and I apologize, this is not projecting well, but another thing which is not captured in this is there are certain drugs which you all know about, some of which you may not know about. This was a study that we recently published using a drug that's used pretty commonly for breast cancer, an oral agent, and it was increasing creatinine, and patients were worried about it, or physicians were worried about it, and it turned out that when we did the clinical studies, it actually didn't change GFR at all. It actually it affects the secretion of creatinine by the proximal tubule. So that's another factor, and with all the drugs that are coming down the pike, you always have to think about whether or not this drug may be already proven or not proven, may be increasing creatinine just because it's interfering with one of these transporters that secrete creatinine into the tubule. It turns out that metformin is also secreted, and in fact, that's one way to look at this, to look at the excretion of metformin, which is used in a lot of patients, but here is part of a clinical study, whereas if you used an iohexol clearance, there was no difference. Despite the fact that creatinine went up, there was no difference in iohexol clearance. And also, this relates to the diagnosis using biomarkers. And here's an example for case of NGAL. You've heard about NGAL. And this is an analysis of the ability of NGAL or IL-18 to either urine NGAL or plasma NGAL to predict AKI. And in fact, this receiver operator curve, if it's a perfect biomarker, that is, if it predicts it in a sort of perfect way, what this curve would look like would go up and then across. Okay, but it's not doing that. And so people have rejected the notion of using many of these biomarkers, when in fact the problem is not necessarily with the biomarker, it's with creatinine that's used as the standard for the diagnosis. So I think it's important to, again, recognize that. That's the reason why we're all frustrated by the fact that these biomarkers are not more used more in clinical practice. They are, in general, very poor in terms of their positive predictive value. So if NGAL goes up, will creatinine go up? Well, no, it won't. Maybe it'll only go up in 20% of the cases. But that's because people have renal reserve. So they may have injury related that's picked up by the NGAL or some other biomarker, but there's not enough injury to increase creatinine. On the other hand, the negative predictive value of many of these markers, including NGAL, is quite good. So it's 90% or so. So if there's true injury and creatinine goes up, then it's likely that NGAL will go up. Okay, so which basically means that if NGAL doesn't go up and you're treating the patient with cisplatin or you use another biomarker, if it doesn't go up, then that's useful clinical information because it suggests that you don't have injury. But we're not using them yet for that reason because the field just hasn't paid attention to actually testing them in that context in a way that the FDA would approve them. For example, here's the case with NGAL. The positive predictive value is 0.28, not great. The negative predictive value, however, is 0.97 or 0.99, really very good. But if you put them all together and you do a receiver-operator curve analysis, then it comes out like this, and people say, well, it's not useful. Okay. And we actually looked at this in doing a mathematical analysis and that said, okay, let's assume that we have a perfect biomarker, true positive here and true negative. Let's say the biomarker is perfect, but our gold standard is imperfect, like creatinine. So let's say creatinine has an 80% sensitivity and an 80% specificity here of creatinine. It turns out that the perfect biomarker would, when analyzed, have a sensitivity of only 50%. It would have a specificity of 94%. But you see, it wouldn't seem very good, but the problem is not the perfect biomarker, it's creatinine. Another example here, this was studied with using KIM-1 and saying, okay, this was patients receiving cisplatin and for mesothelioma. Let's assume that everybody who has a high KIM-1 had acute kidney injury or some tubular injury. But let's assume, because it's really very high, and this value is actually very high. How good would creatinine be as an indicator of acute kidney injury? So twisting it around. And you see that in this study, in this way of looking at it, creatinine was completely useless because our area underneath the curve of 0.55 basically means it's chance. So if we started out with KIM-1 or NGAL rather than creatinine, we would certainly be discarding the use of creatinine in acute kidney injury. We wouldn't discard it completely, but it would be it wouldn't have the kind of focus that we have on this measure. Okay, so in thinking about the pathophysiology, I still think that this is a useful way. This is an old-fashioned way, but I think that this is a useful way of thinking about the patient when you approach the patient. You know, is it pre-renal? Is it renal? Is it post-renal? And then if it's renal, and we won't go through all the criteria, and you're familiar with obstruction and things like that, or sometimes it's hard to distinguish pre-renal from renal, and that's where urine analysis, you think we could do better with biomarkers. You heard about cardiorenal syndrome, you heard about liver in the kidney. Those are all important issues in distinguishing this. But then if you think about, obviously glomerular disease is part of the kidney and it's it's part of the intrinsic kidney component. Interstitial and vascular and tubular, there's overlap in those and perhaps not as nicely separated here. The numbers in parentheses are roughly percentages intrinsic renal AKI, whereas sepsis, you see sepsis we've put in the bottom left-hand corner. And then more mechanistically, and you may be able to read this more easily in your slide, in your book, but essentially in going from a healthy kidney to an injured kidney, there's tubular injury, there's endothelial cell activation, there's obstruction of the tubule, there's leukocyte recruitment, and vascular injury. And at this stage, if the kidney is injured, it can repair, in particular if the baseline kidney was truly healthy, or it can have an impaired repair process and ultimately lead to fibrosis. And so I'll talk a little bit about the normal processes of repair and then a little bit more about the abnormal processes. But I also want to say, when we deal with pathobiology, again, another issue with just lumping, as the definition tends to do, is that there's very different pathobiology depending on whether it's an increase in creatinine associated with volume depletion or an increase in creatinine associated with ischemia or some true tubular injury. And this was some work that Jonathan Barash at Columbia did. And essentially, this is now mouse studies where he induced a mild injury that increased the creatinine from 0.2 to 0.3. The baseline creatinine in the mouse is 0.2. So again, a 50% increase, or he induced an increase in creatinine by volume depleting the mouse. So two very different ways, but certainly both relevant to our patients. And then he asked a simple question is, okay, take the kidney and let's analyze it by looking at proteins, or in this case, looking at RNA. And so with red being genes that are upregulated and green being genes that are downregulated here, and white also being genes that are not activated. But you can see this is the volume depletion case, and this is the ischemia reperfusion case, entirely different in terms of the interactions. So volume depletion, again, potentially obvious to some of you, but volume depletion evokes a very different response in the kidney than does ischemia reperfusion, and therefore any kind of prescription, any kind of therapeutic approach that doesn't take into account the fact that a 50% increase in creatinine in one patient may be entirely different than a 50% increase in creatinine in another patient is ill-directed. Okay? We need to get much more personalized about it, and that was really the topic of the editorial, was we have to go back to the old days and think about pathophysiology and not just take an epidemiologic term like creatinine and say, I mean, it's a functional term, it's useful, but we can't take studies that have been done showing that there's, an increase in creatinine increases the susceptibility to death and everything, and just sort of forget about the pathobiology, which is very different patient to patient. My notion in the pathobiology is that a lot of it relates to the vasculature, even in the context of nephrotoxicants. Now, nephrotoxicants do have, they sort of stick out a little bit from this because they do have a direct effect on the tubule, in particular the proximal tubule, or there are some things that have direct effect on the glomerulus, obviously. But a lot of things do come down to local ischemia. Whether that's the standard ischemia reperfusion, whether that's decreased perfusion or decreased intravascular volume, whether that's atheromembolic disease or vasculitis or scleroderma or preeclampsia. Many of these carry over to pathobiology that's very similar. Some with nuances that are in addition to the ischemia. Some really can be explained entirely by the ischemia. The other thing to recognize, and this is, I think, very important to think about. I think there's going to be more attention clinically as we get better tools to look at this, and that is the vasculature. Remember the vasculature of the kidney, and the fact that in particular in the outer medulla here, this is obviously oversimplified in the cortex. The tubular structures are much more convoluted than this, but the purpose of this slide is really to point out the medulla, in particular the outer medulla, and most nephrons in humans, not all, but most nephrons in humans go through the outer medulla, and hence a problem here with perfusion of an area that's already hypoxic because of the countercurrent exchange properties of the vasa recta. If you do anything to impair this further, so what might be something you would do? Well, one of the things that we're probably doing to many of our patients, either we're doing it or they're doing it because of the pathobiology, is increasing the fluid pressure or increasing the interstitial pressure in this area of the nephron. Because the kidney doesn't expand, we all know, and because the capillaries are leaky with sepsis and other things that relate to our patients who have these increasing peripheral edema. And therefore, if we obstruct this area, we're going to get local ischemia. There are issues relating to the vasculature, the glycocalyx of the endothelial cells, the lining material, the sort of glycoproteins that protect the endothelial cells. Those break down with injury, with sepsis, and that predisposes to leukocyte adhesion to the endothelium and activation of inflammation. This is a mouse model of ischemia that we published, whereby we looked at perfusion in the mouse to the cortex, outer medulla, and inner medulla. And the bottom line here is with a 30-minute, or actually this was about 26 minutes of ischemia, that it took 24 hours for perfusion in the mouse to get back to normal. And most of the concern was not total renal perfusion. That comes back very quickly. But it's that perfusion to the outer medulla which gets impaired. And I would argue that that's happening in humans a great deal. And so much so, the intensivists have actually recognized this. And so pouring fluid into patients who have marked peripheral edema, who have capillary leak, and seeing the urine output drop is probably an iatrogenic complication. So one has to be really careful. There's a balance between blood pressure and this phenomena that's probably going on in the outer medulla. And I use the word probably because we actually don't have right now good methods that are being applied, although the ultrasound methods that we used in the mouse could be applied in humans, and people are beginning to do that. But we have to be cautious in treating patients with AKI and not to basically just increase their edema in the outer medulla and therefore shut down their kidney function. This happens, I believe, very often in sepsis. Okay, the other thing, and I want to again stay on time, so the other thing I think you need to really remember, because this is contaminating the literature, in particular on sepsis. It's frequently said that there isn't as much tubular injury in sepsis, so therefore what's the problem? And I just want you to remember that the nephron is a very complicated structure. It's much more convoluted and complicated than is in most textbooks. The vasculature of the nephron comes from at least 10 or 15 glomeruli, not as it's shown in textbooks from prominent nephrologists, that there's a functional unit that usually incorporates the vasculature with the tubule and basically makes it one functional unit. That's not the way the nephron is. The nephron is a functional unit from a point of view of tubule structure, but the vasculature comes from a number of different glomeruli. So if you shut down one of these glomeruli because of glomerular disease or because of vasoconstriction in a particular region of the cortex or the inner level of the cortex or so, you're going to make a part of the nephron ischemic. And that part of the nephron might be here, okay? Or let's say it's here, up here. This part of the nephron's ischemic. You then get cells that come out of the nephron, you obstruct the nephron, and the nephron becomes dysfunctional. If you take a biopsy here, let's say, and you look at the tissue, you're going to say, okay, it looks like a little obstruction, but the tubular cells look fine. And so then you're going to say, well, we have to explain the fact that patient's creatinine is 7 in some other way because it's not clearly tubular injury. But again, those arguments from very prominent people, people I have a great deal of respect for, and that's why I keep slowing this slide all over the place, because in fact, they don't appreciate the fact that you can't expect to have tubular injury seen in a random biopsy, because of this phenomena. Okay, so people have focused on the mitochondria. This is when we talk about pathobiology. The mitochondria are believed to be really important players in the pathobiology, and there are some therapeutics like nicotinamide, which have been shown in animals to be protective of mitochondrial function. And Samir Parikh at the Beth Israel here in Boston has a number of very prominent papers in this area, and this kind of technology is being applied to humans in sort of early clinical studies because nicotinamide is relatively safe. In terms of treatment, to show this one slide, every single time we have to lead discussion of AKI, you clearly have to talk about dialysis. And so this, because that's the therapy that we see used in many of the patients in the hospital. And this was a study that repeats many other studies, but in sepsis, where patients were randomized to patients who developed failure, so had a 200% increase in creatinine, were known to be septic. They were randomized to being dialyzed right away or within the next 12 hours or waiting for 48 hours to dialyze them. And the study was stopped because using a 90-day mortality, they were stopped for futility. So there was no difference found between early dialysis and late dialysis in these patients. There are a number of drugs that have been tried and are in clinical trials affecting, as I've tried to put them together because they relate to the pathobiology. So anti-inflammatory agents, antioxidants, agents to improve the mitochondrial function, and other agents to facilitate regeneration. Okay, so I'm going to be tight here. Let me just say that there are processes relating to normal repair. We did an experiment here in animals or mice at 1 day old, hoping that we could get the nephrons to replace themselves, to regenerate, and thinking that maybe at 1 day of age, because we know there's nephrogenesis occurring in the mouse after 1 day, or at 1 day, 1 to 3 days after birth, could we then get the nephrons to regenerate? Could we then understand that process? Could we then apply that to some kind of therapeutic in humans? Bottom line is we did cryo injury to the kidney. We can't see this very well, but here we wiped out all the nephrons here. Around it, this is KIM1. These are intact nephrons, proximal tubules that can produce KIM1 when they're injured. Here there's no KIM1 because the tubules were completely wiped out. And the bottom line was we couldn't get regeneration of new nephrons. What we could get was reasonable repair, but all from basically proliferation of nephrons that were already there. So that we got hypertrophy of the nephrons surrounding the area, and it almost filled in completely with leaving very little scarring. But nevertheless, we couldn't get any new nephrons. So you can't make new nephrons right now. And in thinking about the repair process, it turns out that the cells that do repair the nephron, again, if you haven't destroyed the nephron completely, but if you've sloughed some cells in the epithelium, you basically, those cells come from endogenous cells. They don't come from stem cells in the interstitium or from the bone marrow. Okay, so let me just say one thing, because I'm over here. There's a very close connection between AKI and CKD, this maladaptive repair. If you look at patients who are admitted with a diagnosis of AKI to the hospital and compare them to patients who have a diagnosis of CKD coming into the hospital, that if you look over 700 days or approximately 2 years after hospitalization, that those patients with AKI actually had an equivalent chance of getting to end-stage renal disease, as did those patients with a diagnosis of CKD. And if AKI was superimposed on CKD, there was enormous increase in the incidence of ESRD. Okay, and this is reflected in animals where even mild aspects of acute kidney injury here, even moderate or very mild, 42 days later, you still have not a completely normal kidney. You have residual interstitial abnormalities, which of course are much greater with more severe part injury. Let me, if you now superimpose AKI on diabetic kidney disease, we published a review last year on this. There are many, many interactions. Diabetic disease affects the vasculature, and suffice it to say that the progression of chronic kidney disease, whether it's diabetic or not, is likely influenced in important ways by clinical and subclinical bouts of acute tubular injury, which may not be manifest in a change in creatinine per se, because the patients are not hospitalized, they're at home. And in terms of the treatment, ultimately, that we find for acute kidney injury, I think will carry over to chronic kidney disease. And I would argue that maybe the treatments that we find to be effective in chronic kidney disease may be actually effective in acute kidney injury, and bringing these two fields much closer together. The last thing, maybe I'll just show this slide, where there is activity in trying to make new nephrons from stem cells, and these are the kinds of structures that one can get. And at a close-up, this is work initiated by Albert Lamb and Ryuichi Warzani, following up on that. And here you have these structures. These are, again, generated purely from human stem cells, and you get structures of glomerular-like structures surrounded by what looks like a Bowman's capsule moving into a proximal tubule. And here's proximal and distal with TAM-Horsfall protein in between. So there's a good deal of interest here in trying to move to the next step of not only making kidney cells from stem cells, but actually using some of these technologies to understand better how we can take the endogenous kidney and actually regenerate nephrons. So with that, let me end there. So thank you very much.